Shall we start, sir?
Yes, you can start.
Good morning, everyone. As the newly elected chair and convener, myself, Dr. Saraswati Nashi, and Dr. Jyotsna would like to begin by sincerely thanking the IN President, Dr. Lakshmi Narasimhan sir, and Secretary Dr. Meenakshi Sundaram sir for this opportunity. We would also like to appreciate and acknowledge the excellent work done by the previous chair and convener, Dr. Devyani Garg and Dr. Ajay Asrana, for the strong foundation which they have led, and we wish to continue and build upon the previous efforts by them. So, on behalf of the IAN, YNF, I would like to extend a warm welcome to everybody here. I extend my respectful greetings to our senior moderator, Professor Madhu Nagappa Madam, who is an accomplished neurologist and also a researcher with special interest in neuromuscular disorders. With this, I request Professor Madhu Madam to take over the proceedings. I also wish all of you a stimulating academic session. I would like to invite Dr. Jyotsna to say a few words before we move on to our senior moderator.
Yeah, good morning, everyone. Thank you, Dr. Saraswati. I'm Dr. Jyotsna, and I'm a pediatric neurologist at Apollo BGS Hospital, Mysuru. And I thank the IAN office bearers for electing us. There is a pediatric and adult representation this year. And together, Dr. Saraswati and I, we hope and promise to deliver and carry out as many academic sessions as possible this year, bringing together, connecting, collaborating, and growing together young neurologists across India. And I thank all the senior neurologists who are supporting us in this endeavor. Over to you, Saraswati, and hoping for a brilliant debut session today.
Thank you. We also encourage our participants to type their questions in the chat box. Thank you, madam. Please take over the proceedings.
Good morning, one and all. It's indeed a great pleasure to be a part of this forum, the Young Neurology Forum, which promises to be very exciting. And we have two cases today presented by two very accomplished residents and two moderators for the session. So the first case will be moderated by Dr. Sumant S., who has been my colleague and friend for the last 1 decade. He's a consultant neurologist at the Bangalore Baptist Hospital. So I request Dr. Sumant to take over the proceedings.
Good morning, everyone. Thank you, ma'am. Before we start, I just like to thank Dr. Saraswati for inviting me to be a part of this part of this session. So let's just start. I'll invite Dr. Sandeep Kaur, who's a senior resident in CMC Ludhiana, to start her case presentation.
Good morning, teachers, and thank you for this opportunity for presenting a case in a Young Neurology Forum. And now I would like to start my presentation. Is my slides visible?
Yes, yes.
Am I audible?
Yes,
Yes, yes.
My slides are visible, sir?
Yes.
Okay. I'm presenting a case of 55-year-old male, a Muslim by religion and hailing from Jammu and Kashmir. He educated up to 10th standard. He presented to us with chief complaints of imbalance while walking since last 5 years, history of falls since last 4 years, numbness since last 3 years, and weakness involving all 4 limbs since last 2 years. History date backs to 5 years when relatives and colleagues first observed that the patient had a tendency to sway towards the right side while walking. It was insidious in onset and gradually progressive. Initially, the swaying was only noticeable during the fast walking or when distracted, but over months it became evident even during the routine ambulation. It increases at night and while walking on the uneven surfaces. He started walking with looking towards ground due to fear of fall. It was not associated with history of vertigo, sense of spinning, not associated with any ear symptom, no history of any tremulousness of hands or head, and it was not associated with any change in voice. When he was 1 year into the illness, he developed falls which were more towards the right side, but few falls to the left also, and mainly during walking on the uneven ground and during turning, with approximately 5 to 6 episodes of falls per month. It was not preceded by any graying of vision, lightheadedness, palpitation, or loss of consciousness. And over the time, with increasing unsteadiness and reduced confidence in the gait, he began requiring support from the wall or nearby object, especially in the unfamiliar environment or on the uneven surfaces. He also gives the history of numbness, which began in the feet and then gradually progressed upwards to involve the knees and later the trunk up to the level of the umbilicus. He noticed reduced awareness of mosquito bite and difficulty in distinguishing hot and cold water while bathing. He also described marked cold sensitivity in both the feet with significant discomfort even to the airflow from a fan. Subsequently, he developed numbness over the tips of the finger, which started after the foot symptoms, though he is unable to specify the exact interval between the onset of the hand symptom. There is no history of unintentional cuts, burns, or other injuries to the hands or feet. He denies any tingling, pins, needle sensation, or burning pain. There is no history of any sensory symptom over the face, and he does not have any complaint of band like or electric shock like sensation and any radicular pain. He gives the history of weight bearing difficulty which started in the right lower limb and over 3 to 4 months with similar history of involvement of the left lower limb which was gradual in onset and progressive. Initially it started with difficulty in climbing the stairs, mostly while climbing upstairs then the downstairs, and difficulty in getting up from a toilet seat. It was associated with buckling of both the knees, and subsequently he developed difficulty in wearing slippers, particularly in getting the feet into the slippers, and he began to take the support from the wall while doing so. He also described the history of slipping of slippers without his knowledge, following which he stopped using the chappals and started wearing shoes. And he started walking by lifting his legs higher than the usual. And when he was 4.5 years into the illness, he developed difficulty in hand activities like buttoning and unbuttoning, unbuttoning the clothes, tearing the chapati, holding a spoon, and grasping a cup. There is no history of difficulty with overhead activities such as combing hair or reaching above the head, and no difficulty in lifting the head off the pillow. He also reports difficulty in getting out of bed and turning in the bed. There is no history of any thinning or visible wasting of the limbs, but he gives the history of occasional muscle twitching. In autonomic symptom, patient gives a history of loss of air over the distal leg and feet, along with increased sweating over the face and upper trunk, and also it also he also gives the history of decrease in libido. There is no history of any postural dizziness or palpitation. He has a long-standing bowel symptom in the form of bloating, but no history of chronic constipation, no history of any bladder symptom, including retention, incontinence, or sense of incomplete emptying of the bladder. In negative history, there is no history of any memory impairment, behavioral changes, hallucination, delusion, or mood disturbances. No history suggestive of any cranial nerve involvement. No history of tremulousness of hands during activity. And no, it was not associated with any slurring or scanning of speech. No history of any stiffness, slowness of movement, involuntary movement, or abnormal posturing. No history of any tremor at the rest. No history of any systemic symptoms in the form of fever, joint pain, weight loss, loss of appetite, abdominal pain, or chronic headaches. No history of any toxin or alcohol exposure. No history of any high risk sexual behavior. There is history of endogenous medication after symptom onset is present. In current functional status, the patient is dependent for most of his activity of daily living. In past history, he is known case of type 2 diabetes mellitus since last 10 years. In personal history, he is non-vegetarian and no history of any addiction. In treatment history, he was started on oral steroids, that is 40 milligram once daily from outside hospital after keeping the possibility of CIDP since last 2 years. However, he was taking the steroids intermittently and with no improvement in the symptoms. In family history, the patient was born out of consanguineous marriage. He later married his maternal uncle's daughter. She was also symptomatic at childhood and died at around 32 years of age. He has two children from his first wife, that is consanguineous marriage, and both children developed the similar symptom in childhood with the onset at around 8 and 12 years of age. In summary, my patient is 50-year-old male born of consanguineous marriage with gradual progressive illness presenting with asymmetrical onset gait unsteadiness, sensory motor weakness involving lower limb proximal and distal and upper limb distal with truncal weakness, sensory involvement up to the umbilicus and autonomic feature without any cranial nerve, extrapyramidal, pyramidal, cognitive or sphincter involvement. In symptom localization for gait and steadiness, my first possibility is sensory ataxia due to involvement of the large fiber involvement, that is non-length dependent neuropathy and dorsal column involvement. In numbness till the umbilicus, I would like to localize it to the spinal cord for keeping the possibility of thoracic myelopathy, and second possibility of large fiber neuropathy with non-length dependent neuropathy. And for weakness, I would like it to localize to the polyradiculoneuropathy. And my differential diagnosis are, first is I would like to rule out inherited causes because of the strong positive family history and consanguinity. First possibility is hereditary motor sensory neuropathy, and the second is mitochondrial disorders. But I would also like to rule out the immune mediated neuropathies like atypical CIDPs and paraproteinemias. And though it is less likely, but I will keep a possibility of nutritional, that is B12 deficiency, and infective, that is tabes dorsalis.
Thank you. I think we'll just discuss a few points regarding the history before moving on to the examination.
Yes, sir.
Yes. So, right, it was a nice presentation of the history. Obviously, the family history here is quite a strong clue. What do you think are the atypical features here for a hereditary neuropathy?
Sir, atypical features for hereditary neuropathy, first is it started with the proximal weakness, sir. The weakness, it started with the proximal involvement first and later on the distal involvement, sir. And the other thing is he gives the history of sensory symptom up till the umbilicus. So that is odd feature, sir.
So, I mean, if
And during imbalance, it started with the like asymmetric onset. That is also one odd point.
yes, so asymmetry, early proximal involvement, the sensory level over a trunk obviously are very atypical for a HMSN.
Yes.
But in a neuropathy, when will you expect a trunk involvement? What pattern of trunk involvement can
Sir,
you
in
expect,
cases
especially
of the
especially say in a length-dependent neuropathy
sir in
and
length dependent
non-length
neuro
dependent?
Sir, in length dependent neuropathy, there can be a tent shaped pattern of sensory loss can be there over the trunk. And in non-length dependent neuropathy, like in infectious causes, herpes or paraproteinemias, it can be the truncal involvement can be there because of the intercostal nerve involvement.
So generally, which part of the trunk tends to get involved, say in a length-dependent neuropathy? Where does the
Sir,
involvement start with, and how does it progress?
sir, in the center, sir, like
Yeah. So I mean, it begins anteriorly, right?
yes, sir,
That is those are the longest fibers. They begin anteriorly and then it progresses posteriorly.
posteriorly, yes,
So
sir.
it begins in the thoracic or abdominal regions. Where does it first get affected and why?
Sir, I think it begins in the abdominal region.
Yes, that's correct. It begins in the lower abdominal regions because the nerves
Mm.
have to travel a more oblique course to reach
Yes, sir.
the center. I mean, the anterior part there. So they are a little longer than the
Yes,
thoracic
sir.
nerves, which go along the ribs. They're more horizontal and shorter.
Yes.
What are the other common like neuropathies where you can get truncal sensory symptoms? So you said one herpes zoster, yes, intercostal nerve involvement. You can get
Mm.
trunk sensory symptoms, but that you would expect it to be segmental, right? Like in a
Yes,
radicular
sir.
dystrophy, you probably won't
Radicular.
get such a diffuse sensory loss, at least
Yes, sir.
involvement in herpes. Any other neuropathies which
Sir,
can involve trunk?
sir, in diabetes, paraneoplastics, and amyloid related or porphyria.
Yes. So porphyria, diabetic truncal neuropathies, herpes zoster, and probably Tangiers disease also tends to
Yes,
involve the
sir.
shorter
Thank you.
nerves. So that can
Yes,
also cause trunk symptoms before involving the distal limbs.
yes.
Okay. So regarding family history, uh, you showed a very nice pedigree chart. Can you interpret that pedigree chart, sir? Can you tell me what the inheritance pattern might be if this is an inherited disease based on the pedigree chart?
Sir, sir, likely to be autosomal recessive, sir.
Okay. Why?
Sir, because the in the my patient, he is only affected, and there is no history of the no history of similar symptoms in the parents of the patient. And the other thing is, sir, there is the both husband and wife, when they are affected, the only children from the first marriage was affected. The children from the second marriage are not affected, sir. They are not symptomatic.
Yeah. So yeah, but the clues here will be consanguinity for
Yes,
the children who are affected and the skipping of generations. And as you said,
yes,
the children along with the unaffected wife don't seem to have the disease. But is it
mm.
possible that some of them have the disease, but not very prominent? I mean, is that possible in CMT?
Yes, sir. It is possible because they can have the like findings on examination, but
Yes. So
it is possible that they are not symptomatic.
yes, so, there'll be very mild symptoms or because of
Yes,
reduced penetrance. So what will you do then? How
yes.
will you? What further can you do, like for a family history? I mean,
So first
not
is
just
I would
history.
like to,
Yeah,
sir, examination of the other family members, sir.
yeah. So yeah, clinical as well as maybe even electrophysiological if you
Yes,
want to be very sure. So
yes.
those two things may be important. What about acquired neuropathies? Is it possible that this man has an acquired neuropathy? Yes, I mean the family history is very strongly pointing towards hereditary. Uh,
Yes, sir.
if he has an acquired neuropathy, can it be diabetic neuropathy? You said yes, 10 years of diabetes.
Yes, sir. It is possible, sir, because or it is possible that he has some component of the inherited neuropathy, and with the diabetes it get exaggerated, sir. The symptoms get exaggerated.
Okay. So what else would you ask history for regarding diabetic neuropathy?
Sir, sir, first is the regarding the diabetic neuropathy. So first is the control of the diabetes status, and then he only has this negative symptom, no positive symptom he has. So, and the other thing is, it will be a typical length dependent type of pattern, sir. With in like he has the symptom till the umbilicus, but in upper limb he has only the fingertip involvement, sir. Not even the hands or complete hands or till the elbow also. Even he has this truncal involvement.
Yeah. So can you get non-lent dependent neuropathies in diabetes?
Yes, sir.
Yeah. So can you give some examples? Like the typical one, as you said, is a lent dependent polyneuropathy. What are
Yes,
the
sir.
little atypical diabetic neuropathies which may not be lent dependent,
Sir,
especially proximal?
so diabetic amyotrophy,
Okay. Or what you call as lumbosacral radiculoplex.
lumbosacral radiculoplex.
Okay. Yeah, you can also get ischemic and entrapment neuropathies.
Yes, sir.
Also, although those would tend to be mononeuropathies, not so diffuse in distribution.
Yes, sir.
So the other things you should probably ask for in a diabetic patient is whether they have any symptoms of retinopathy or nephropathy. So
Yes,
look
sir.
for other microvascular complications.
Yes, sir.
Yeah. So what about immune-mediated CIDP, paraproteinemia? What do you make out of the steroid unresponsiveness? Do you think that's a very strong history here to rule out immune-mediated neuropathies?
No, sir. It is not very strong history to rule out the immune-mediated neuropathies, um, because in some the treatment is like immunomodulation with IVIG or so.
Yes. Yes. So I think there are two things. One is, of course, just because somebody doesn't respond to steroids does
Yes,
not
sir.
rule out immune-mediated neuropathies. And we don't know, as you said, he was taking the steroids intermittently. So we are not
Yes,
sure
sir.
how long he has taken the dose, whether it was adequate according to his body weight.
Yes, sir.
Can hereditary neuropathies respond to steroids?
Yes, sir. There are few hereditary neuropathies which can respond to steroids, like some of the studies which shows that CMT1 also, and there is FIG4, sir, in which there is, if there is inflammatory component is present, then they can respond to steroids to some extent.
Fine. Yeah. Anything else? Autonomic system. Autonomic examination.
One of the things is, since you told a very strong family history,
Yes, ma'am.
some the patient's little bit about the childhood history could have been brought out. Like, what was his sports activities, whether he was a very physically active person participating in sports. And
Actually, ma'am, prior to this symptom, he was working in the railway and he used to do all the work like which is requiring the ambulation and walking and
you mean
other
the
things.
fast component, like, making runs in cricket, football, that kind of a thing. If
Okay.
he was able to do that, gives a subtle this thing that, the onset might, because you're telling his children had early age of onset.
Yes, ma'am.
He might have recognized because he himself is symptomatic.
Yes,
The,
ma'am.
so the previous history, that sometimes gives a clue, not always, but that is one good point to tell how much he was participating in sports, or whether he was, not interested because he was not capable of doing like that.
Okay, ma'am.
Since you said autonomic symptoms, one of the DDs you could include is familial amyloid polyneuropathy,
Yes, ma'am.
or traditionally in the HNSN. So HNSN, mitochondrial and familial amyloid polyneuropathy.
Yes, ma'am.
What is the inheritance pattern of familial amyloid polyneuropathy?
Mm,
That is autosomal dominant. So that is one reason why we need not include here actually. So that way you could defend by telling that this is a strong autosomal recessive, whereas
Yes.
that is autosomal dominant. So that way you can, tell them.
Okay, ma'am.
Difficulty in rising from the floor could be due to the ataxia per se, We need to
Yes.
examine before telling the weakness is there or not.
Yes, ma'am.
Did he have any other symptoms of large fiber involvement like wash basin phenomenon, walking on cotton wool?
Ma'am, he gives the history that during the night initially his symptoms were more prominent,
Yeah.
and so
Corroborating with that, is there any history of walking on cotton wool, wash basin
um,
phenomenon was there? That is also another point that you can ask, to strengthen the
yes.
localization features.
Okay, ma'am.
Good,
Yeah,
good,
good. I think we can move on to the examination now.
good.
Okay. In general physical examination, a patient is calm, conscious, cooperative, well oriented to time, place, and person. Blood pressure in lying down is 130 by 80 millimeter of mercury, and in sitting position it was 120 by 80 millimeter of mercury. Pulse rate 20 per minute, pulse rate 80 per minute, and respiratory rate of 20 per minute with the and no palpable or enlarged peripheral nerves. And he has significant kyphoscoliosis and pes cavus on general physical examination. And in in neurological examination in higher mental function, the MMSC is 28 out of 30. He is right-handed and studied till 10th standard. He lost 2 marks in calculation. In cranial nerve examination, he has exotropia with left eye ptosis with bilateral medial rectus restriction more as compared to the lateral rectus restriction, and bilateral element type of facial nerve palsy with rest of the cranial nerve examination normal. In motor examination, there was wasting of the EDB with fasciculations noted, and tone is decreased in bilateral lower limb with normal tone in the upper limb. In power, though he gives the history of some asymmetry, but on examination in the lower limb, it was symmetrical, hip flexion of 3 plus by 5 bilaterally, hip extension of 3 minus by 5, knee extension of 4 by 5, knee flexion of 3 by 5, dorsiflexion 1 by 5 in the right side and 2 by 5 in the left side, and plantar flexion of 3 by 5 with EHL of 0. He had trunk weakness and some neck flexion also weak. In upper limb, shoulder abduction 3 by 5, elbow flexion 4 by 5, elbow extension 4 by 5, and wrist flexion 3 by 5, wrist extension 3 by 5 with lumbricals of 3 by 5 and APB bilaterally weak. DTRs absent, and bilateral plantars were mute. In sensory examination, he was able to, for pinprick, there was a graded sensory loss till T10. In the bilateral feet, he was able to appreciate only 10% of pinprick, and till knee, he was able to appreciate 30%. And in bilateral thighs, he was able to appreciate 50%, and in till the umbilicus, he was able to appreciate 80%, and in fingertips also, he was able to appreciate 80% of pinprick. Soft touch was impaired below the knee, and vibration, it was lost in the all over, like he was not able to appreciate vibration over the spinous process also, upper limb and in the lower limb also. Only forehead he was able to appreciate the vibration. It can be related to this kyphoscoliosis also. Then in joint position sense, the upper limb, it was impaired bilaterally in the thumbs, and in the lower limb it was impaired till ankle, and hot and cold sensation, he was inconsistent in answering. In cerebellar examination, the finger nose finger test, there was bilateral clumsiness of the hand on finger nose finger, and heel shin test was also impaired. The Romberg test was positive, and tandem he was not able to do. In gait, he had a stamping type of gait. So the summary is a 50-year-old male born of consanguineous marriage with positive family history with gradual progressive illness, presenting with asymmetric onset gait unsteadiness suggestive of sensory ataxia, quadriparesis, proximal and distal involvement in both upper limb and lower limb, with truncal weakness with sensory involvement up to the umbilicus, and autonomic features with extraocular muscle involvement and bilateral facial nerve involvement with kyphoscoliosis and pes cavus without any pyramidal, extrapyramidal, cognitive or sphincter involvement. My differential here are inherited neuropathy, that is hereditary neuropathy CMT4, second is CMT1, then mitochondrial, that is Paul G related, and I would also like to rule out immune mediated causes with atypical CIDP, paraproteinemia and PNS vasculitis.
Okay. Okay. So, general physical examination, would you want to add anything else?
Sir,
Since you also considered a coexistent diabetic neuropathy.
sir, like hair loss and
Okay, I mean, those are probably just general features of a neuropathy. So probably
yes,
here
sir.
you should have mentioned about retinopathy.
Yes, sir.
Under examine retinopathy, whether he has features of diabetic retinopathy. Again,
Yes,
that
sir.
would be an additional neuropathy probably. I don't think we'll be able to explain all this with diabetes.
Yes, sir.
So, so you said about you check the BP in lying and sitting position.
Yes,
So
sir.
is there a significant drop?
Sir, because he was not able to stand without support for long duration. So, in sitting,
Yeah, I mean,
and
that's
we can,
acceptable. If they're not able to stand, you can check in sitting.
yes, sir.
Probably you should have recorded the pulse difference as well. How does that matter? Recording the change in pulse from lying to sitting or lying to standing.
Sir, that is like in autonomic function testing at bedside, we can do the heart rate response to the standing.
So we'll
If
come
it
back
is,
to that. I mean, I asked like, so like you're checking postural vitals, right? You're checking BP while lying and then BP while standing.
yes,
So
sir.
concomitantly, you need to check the pulse rate as well. What's the pulse rate while lying and what's the pulse rate while standing?
Yes, sir.
When you check the
So,
BP after 3 minutes, what we traditionally do. How is that change in the pulse important? So if
sir,
somebody has orthostatic hypotension, what does the
yes.
change in pulse rate tell you?
Sir, if there is no significant, like if it is more than not more than 30 rise in the pulse rate, then there is um, like um, there is autonomic involvement. Sir.
Yeah. So whenever there's a drop in the blood pressure,
Yes, sir.
leading to orthostatic hypotension, then if it's non-neurogenic, then there
Yes, sir.
should be a proportionate rise in blood pressure. So, sorry, proportionate rise in the pulse rate on
Pulse rate.
standing.
Yes, sir.
If there is no proportionate rise in the pulse rate on standing, then that would signify neurogenic problem.
Yes, sir.
So some people use the delta heart rate by delta systolic BP as a ratio. So to separate neurogenic and non-neurogenic at the bedside.
Okay.
So what are the other common autonomic function tests you can do at the bedside?
Sir, one is this orthostatic blood pressure, then heart rate response to standing, then sir, isometric hand grip test, sir, and one is this cold pressure test, sir, and mental arrhythmic test is also there, sir.
Okay. So you probably divide them into vagal and sympathetic. So
Yes, sir, vagal and sympathetic, sir.
okay.
So,
Okay. What would enlarged peripheral nerves indicate here? I mean, where do you get enlarged peripheral nerves? Common
sir,
conditions.
Sir, most common is like leprosy um, in demyelinating neuropathy, sir, in amyloidosis, and um, um,
Okay. Yeah, I mean,
mainly in
neurofibromatosis.
neurofibromatosis. Yes, sir.
Okay. In a neurological examination, you mentioned involvement of extraocular muscles.
Yes,
Okay.
sir.
So does that help you in getting a diagnosis? Facial palsy as well. So what are the common neuropathies where you get extraocular movement involvement?
Sir, extraocular muscle involvement in non-inherited, it can be involved in diabetes, sir, and in facial involvement can be there in immune-mediated neuropathies, and
We'll
the
stick to
in
extraocular first. Just
ex
extraocular ophthalmoplegia in peripheral neuropathies. Not very common. In muscle, we see in a lot of conditions. But in
yes, sir. In
neuropathies, to get extraocular muscle involvement, what does it point to? So
sir
you can
in
tell in
inherited
acquired and
inher Yes, sir. In acquired and inherited. In inherited, like CMT4 is known to associated with the extraocular muscle involvement. Then mitochondrial disorder, mitochondrial associated neuropathies also.
and in acquired.
In acquired, sir, diabetes, sir. Then
Okay. GBS probably, right? I mean, if
Yes,
they
sir,
have an
GBS,
overlap with
immune mediated.
Miller-Fisher
Yes, sir.
ophthalmoplegia can be there.
Yes, sir.
And what are the neuropathies where you can get facial palsy?
Sir, diabetes, then GBS, CIDP, and um, um, uh,
Probably sarcoid and
sarcoidosis. Yes,
leprosy
sir.
also, no? Leprosy also, it's quite it's
Leprosy.
an
Yes,
important.
sir. Yes, sir.
So what type of facial palsy is very typical of leprosy?
Mm. I'm not sure, sir.
Okay, so you tend to get something called a branch facial palsy, right? So where there is kind of differential involvement, usually of the upper facial muscles, especially frontalis and orbicularis,
Okay,
because
sir.
of selective involvement of the zygomatic branch. That
Okay,
may
sir.
be a cue.
Okay, sir.
Okay. And what about pes cavus and scoliosis in this condition? How do you kyphoscoliosis and pes cavus? How does it help?
Sir, kyphoscoliosis is also a feature of most of the inherited neuropathy, like CMT4, and pes cavus is also indicative of the long-standing neuropathy, sir.
Yeah. So while pes cavus is a very characteristic feature of inherited neuropathy, it can be seen
Yes,
in any chronic neuropathies, including acquired
yes,
and diabetes, especially. It can be. Why does pes cavus happen? What is the mechanism?
sir. Loss because of the wasting and involvement of the intrinsic muscles of the foot, sir.
Okay. Yeah. Anything else?
Yeah, so very nice presentation, very good. Good
Thank
and
you, ma'am.
interesting case. So three key features in this patient. You know that this patient has a neuropathy, probably inherited because of the strong family history. So the three key features are kyphoscoliosis, cranial nerve involvement, and fasciculations.
Yes,
Right. These are the three
yes.
key features in this patient. Now, history-wise, you found some asymmetry at onset. On examination, did you find any asymmetry?
No, ma'am. No,
There was no
it was not.
asymmetry. So
Yes,
I don't
ma'am.
know. Sometimes we have seen that at the onset, some patients tell asymmetry, but eventually it becomes symmetrical within a short time. So why
Yes,
that happens, I don't know. But inherited neuropathy also though that's a pointer for acquired neuropathy, except
yes.
probably HNPP, where you can have asymmetry.
Asymmetry. Yes,
Hereditary
ma'am.
neuropathy with pressure palsy, you can have asymmetry like a mononeuropathy or mononeuritis multiplex. All
Yes,
other HMSNs, you have a symmetrical this thing, but sometimes at the onset, people do report asymmetry at
Asymmetry
the
involvement.
onset. So that now this kyphoscoliosis, after seeing history-wise, did you go back for history of skeletal deformities in the family? And when was this onset of kyphoscoliosis in this patient? Or he had
ma'am,
not?
I asked him, he was saying that it was there since childhood, and I
So
finding
that
also
might
there
be
since
the
childhood.
onset, you see, that's what we discussed no, sometime. So that might be the onset, kyphoscoliosis as the.
Yeah, the other thing was that you said initially he kept falling to the right side. I don't know if that was because of the trunk bending.
Yeah,
Is
correct.
that
Yes, ma'am.
Because of the
Yeah.
kyphoscoliosis and his imbalance. So then you see the onset might actually be in childhood for this patient, which is another strong pointer for the hereditary nature of the disease. Sometimes,
Yes,
and what you said, CMT4,
yes,
classically
ma'am.
they may have onset with kyphoscoliosis in childhood. That may be the first symptom. Or deafness
Yes,
may be the first symptom, but you said there was no involvement of the auditory nerve.
yes.
Now, this fasciculation is another interesting point you said. So, can you tell any hereditary neuropathies where fasciculations are kind of described in the phenotype? There are some, it's very rare. Some, I think, some hint neuropathy where they have this neuromyotonia fasciculations. And recently, I also read sometime back there's a HMSN proximal form, HMSNP, where
Okay,
they
ma'am.
have a proximal weakness with wasting, fasciculations, resembling a ALS-like phenotype. But in addition, they have sensory involvement, like what you said,
Yes,
large
ma'am.
fiber involvement, impaired joint position sense and vibration sense.
Yes,
And
ma'am.
There's a specific gene mutation in that. I'm not able to recall,
Okay.
but HNSNP is there.
Okay,
Where
ma'am.
they resemble an ALS, they have weakness, wasting, fasciculations. Onset is in adulthood only, like a Kennedy syndrome. But they have, like Kennedy's, they also have additional sensory impairment, large fiber involvement. And there's a specific gene described for it, but I'm not able to get. Hint neuropathy is another neuropathy, but that is motor predominant, hint neuropathy, HINT. So the hint is in the neuromyotonia for the diagnosis.
Okay.
So these are the three key features: kyphoscoliosis, ophthalmoplegia, and fasciculations. When it comes to mitochondrial disorders, can you tell which mitochondrial disorder has ophthalmoplegia and neuropathy? Mitochondrial
Ma'am,
disorder is a broad name. So which
yes,
mitochondrial
ma'am.
disorder has ophthalmoplegia and neuropathy?
Ma'am, this Paul G related or CPEO and
Which one? One is Paul G. That's an excellent answer.
yes,
Apart from
ma'am. NARP, that not related.
that, that's retinitis
Retinitis
pigmentosa.
Retinitis pigmentosa. Yes, ma'am. Not ophthalmoplegia.
Mengi syndrome can have.
Yes, ma'am.
But this person obviously doesn't have gastrointestinal symptoms, which are universal.
Yes,
But they
ma'am.
also have this ophthalmoplegia and neuropathy. Paul G is a very good answer. That might be one strong consideration in this patient. So in your order of differential diagnosis, which one would you put?
Sir, ma'am, because of this kyphoscoliosis since childhood and extraocular muscle involvement, I would like to keep CMT4 as my first muscle.
Correct.
You'll have to also explain the sensory findings, which are a bit atypical here. So, so the trunk sensory findings, do you think is something separate? Is there a coexisting myelopathy?
Sir, initially we thought of because of kyphoscoliosis, there can be some myelopathy component also there, which
So why do you
can
think
be.
it does not have the other myelopathy features here? Like you said, no extensor plantar reflexes are absent.
Yes, sir.
Probably they're masked by the severe LMN involvement, right?
Yes.
How would you differentiate a sensory loss of the trunk from a myelopathy from that from a len-dependent neuropathy?
Sir, in myelopathy, there will be a sharp sensory level, sir. But in neuropathy, there will be a tent-shaped pattern, or the level will not be that sharp. So,
I think in your diagram you have indicated that anterior and posterior involved equally.
yes,
But I
sir.
guess in a len-dependent neuropathy, you would check for an anterior-posterior gradient as
Anterior,
well.
yes, sir.
So whether there is a graded loss anterior-posteriorly as well.
Okay, sir.
But you see, that's very severe. Vibration is lost in upper limb also. Upper limb till what level did you check?
Ma'am, he was not able to appreciate at the clavicle also, but only the forehead he was able to appreciate that it is vibrating.
Okay, then, that I don't know if that myelopathy would be very unlikely with, may just be a very severe generalized neuropathy with large fiber predominant involvement, I guess.
Did he have pseudoathetosis?
Pseudoathetosis, ma'am, he described that he was not able to hold the chapati in his index finger and the thumb, between the thumb. He need to clench this. So I don't think whether if I will call it as pseudoathetosis or not.
No, examination wise, like, yeah.
Uh, as such, it was not there.
So, but the incoordination you found on examination is sensory or cerebellar? I mean, some of these hereditary neuropathies can have central involvement. So, do you think he has
Yes.
an additional cerebellar?
Sir, in sensory, like it will be more pronounced with eye closure, and it is less with the eye opening.
So, there is some improvement in coordination with eye opening.
Yes,
Although
sir.
with very severe involvement, it may be difficult to appreciate that improvement. But nevertheless, I think once you have a peripheral nerve case, you must do both eye open, eye close examination for both finger nose and heel shin test.
Okay, sir.
Okay. Yes. So, yeah. How will you now finally, what is your order of differential diagnosis now in this patient?
Sir, this is my order
Okay.
of
So which
differential
the
diagnosis.
most likely one is you feel a
Same.
hereditary neuropathy, CMT4 is most likely.
Yes, sir. But he gives the history of symptom onset at around like 50 years of age, but the kyphoscoliosis was present since childhood. So I kept it as CMT4 because CMT4 is childhood onset only, sir.
Sure.
Yeah, kyphoscoliosis is described in many CMTs,
Yes.
PMP22, NPZ, CMT4, but the CMT4 classically that kyphoscoliosis at onset is one of the features, I think.
Yes.
Yeah. So how did you approach this case? What were the investigations?
Sir, we did the routine blood investigation that were normal, and CSF was not done because of the spine deformity, sir. Then we did the NCV, sir. It was non-stimulatory in the most of the nerves, but the left ulnar showed the decreased nerve conduction velocity, sir. It is 25 meter per second, and
This help
then
Does this help in
once
differentiating an acquired and hereditary neuropathy? So what would you
yes,
look for in a nerve conduction study?
so 1 second, sir. In Sir, in nerve conduction study, in cases of the hereditary, there will be symmetrical slowing, sir. No conduction block and no temporal dispersion, sir. And the difference between the median and ulnar slowing will be less than 5 meters, sir. And in the acquired, sir, there will be asymmetrical slowing with temporal dispersion and conduction block can be there.
So that is what is characteristically called as uniform slowing, right?
Yes,
So
sir.
yeah, so between the nerves as well as between proximal and distal, you have the same amount of slowing, unlike
Yes,
acquired neuropathies with conduction block and temporal dispersion.
yes,
So I'm not sure. I don't know if this nerve conduction study will really help you because most
yes,
of it
sir.
is inelicitable.
Yes, sir.
Okay.
We did the
Yes.
EMG, sir. It was suggestive of no spontaneous activity in the bilateral tibialis anterior, vastus medialis, APB, FDI, and brachioradialis. And MUAPs were of large amplitude, polyphasic with reduced recruitment and interference pattern. And it was suggestive of neurogenic patterns, sir. Then, because of some eye odd features like eye involvement and all, we did the MRI brain, sir. It was suggestive of only partial empty sella with some perioptic nerve sheath thickening. Otherwise, some atrophy is there, no significant findings, sir. And in MRI whole spine, there was some discal changes involving the cervical, lumbosacral spine, and no significant canal stenosis or cord signal with cervical lordosis, thoracic kyphosis, and lumbar lordosis is seen. Then we did the genetic testing, whole exome, and it came positive for SS3 TC2 gene, that is with homozygosity and autosomal recessive pattern, which was pathogenome.
So here genetics confirm the diagnosis. Yeah. So what would you do if, say, this came back as negative, or if it was shown as a variant of uncertain significance? That does happen. None
Sir,
of these are foolproof. So what would your approach be then? Would you still stick to hereditary neuropathy if this came back negative or uncertain?
Sir, firstly, we will see for the phenotypic approach, then and the family history, sir. With phenotypic and genotypic correlation, we will see, sir. If
That
and
if you have a VUS, yes, then the first thing is again you'll review the phenotype,
yes, sir.
and if it fits in, yes, you would still consider. What else could you do for variants of uncertain significance?
Sir, um, to rule out the other causes, sir, like
I mean,
immune.
specifically from a genetic point of view, how else would you approach a variant of? Now, you have a phenotype where it is at least the early onset kyphoscoliosis, ophthalmoplegia, and other things look fairly typical for CMT4.
Yes, sir.
But I mean,
Sir,
this is a general concept because we are using genetic tests so much nowadays. When the phenotype correlates, but it's a VUS, what
sir,
else can
family examination of the family member and testing of the family members, sir.
segregation analysis or testing of family members is one thing.
Yes.
Now, suppose this had come as no variants identified, then what would your approach be for this patient? Would you still say, okay, it is hereditary, it's a clear-cut hereditary, we'll not do anything else, or would you consider doing something else?
Sir, I would like to rule out the treatable causes, like to rule out the other causes also. So, nerve biopsy I will do, sir, to rule out the other.
Right. So what would a nerve biopsy show in a hereditary neuropathy? What are the typical features?
Sir, in hereditary neuropathy with demyelinating type shows the onion bulb appearance and no inflammatory infiltrates will be there.
Usually uniform loss of myelin, onion bulb.
Uniform loss of myelin. Yes, sir.
Yeah. So these would be the features. Yeah. So how do you manage this patient?
Sir, only symptomatic management with genetic counseling and multidisciplinary approach with the prevention of the complications. Sir. But there are few trials are going on, like for a few genes in the CMT also. But
What would be okay? Yeah, I mean, obviously, we will involve rehabilitation and everything else. That's symptomatic treatment. All that is fine. What do you
yes,
think is the most important thing? He seems to have another major risk factor for neuropathy. Do you think addressing that is very important for him? He has diabetes, no?
diabetes, yes, sir.
I mean, if his diabetes becomes uncontrolled, then that probably will hasten the progression. He'll develop another neuropathy on top of this. So,
Yes, sir. Adequate control of
yeah,
blood sugar level and
yeah. Other things you can rule out simple things, thyroid, B12,
yes,
ensure
sir.
that they are all normal.
Yes, sir. That no. B12 was on a bit borderline, but it was
Yeah, lower side. So probably supplementing that also.
yes.
Mm, In this SHTTC2, one of the important cranial nerve is deafness, sensory neural deafness.
Yes, yes,
So
ma'am.
auditory screening would be one important thing, no? Doing pure tone
Yes,
audiogram and BAER. That is another
yes, yes, ma'am.
excellent, very good case.
Thank you.
Something to show about the
Yeah, I think
Yes, ma'am.
yeah.
The hereditary neuropathies, these are heterogeneous group of disorders with the clinical feature of insidious onset and indolent course over the years to decade. They constitute 40% of chronic polyneuropathies, and they are frequently underdiagnosed or misdiagnosed. Family history is most important but difficult to obtain. So, in the classification of inherited neuropathies, first is clinical classification, that is isolated neuropathy only, which is HMSN or CMT, hereditary sensory autonomic neuropathy, then distal hereditary motor neuropathy, and HNPP, and neuropathy with multi-organ involvement, that is familial amyloid neuropathy, mitochondrial, spinocerebellar ataxia, and HSP phenotype. Then electrophysiological classification, demyelinating, that is with nerve conduction velocity of less than 38 meter per second, and intermediate with 38 to 45 meter per second, and axonal with nerve conduction velocity of more than 45 meter per second, and genetic, that is autosomal dominant, autosomal recessive, and X-linked type of inheritance pattern. In close to an inherited neuropathy for clinical, there will be foot drop, recurrent painless foot ulcer, major sensory loss without positive symptoms, poor or absent response to immunotherapy. On examination, palpable thickened nerve with skeletal abnormalities like scoliosis, pes cavus, and inverted champagne bottle leg with hammer toes, and neurological signs in relative. However, a negative family history does not exclude the inherited neuropathy because of like early parental death, small family size, or autosomal recessive inheritance. The CMT, it was first described in 1886 by Charcot and Mary in Paris, and Tooth in the London. It is the most common inherited neuropathy, prevalence of 1 in per 2500 individuals. Approximately more than 100 genes can cause CMT. In CMT, the further classification, the CMT1, it is autosomal dominant inheritance pattern with PMP22 gene duplication. It is demyelinating type of neuropathy with childhood onset and NCV suggestive of very slow nerve conduction velocity. The CMT2, it is autosomal dominant with CMT2A is most common type, and MFN2 mutation with it is axonal type of neuropathy, and optic atrophy is the common feature. Then CMT3, it is also known as the Zarin-Sota disease, which is prominent proximal and distal weakness. The genes involved are PMP22, MPZ, and EGR2. They have the severe hypertrophic neuropathy, which is childhood onset and delayed motor milestone. Then CMT4, I will describe it later, and CMTX, which is X-linked inheritance, GJB1, that is channel protein. Males are more severely affected, and it has the CNS involvement. And on NCV, it has the intermediate conduction slowing, and other are the non-pathogenic CMT genes. So CMT4 is the autosomal recessive. It constitutes less than 10% of all the CMT. CMT4A with GDAP1 mutation is most common. Other genes are SH3TC2. It is early childhood onset with progressive motor and sensory impairment. NCV is often suggestive of demyelinating, and CSF proteins will be normal. Pathophysiology, it is Schwann cell and myelin pathology with onion bulb formation and secondary axonal loss. Other common subtype of CMT4 are CMT4A, that is GDAP1, which shows the vocal cord involvement. CMT4B1 or B2 with early foot deformity and cranial nerve palsy. CMT4C, that is severe early scoliosis and cranial nerve involvement. CMT4D with deafness, and CMT4F with profound demyelination and sensory ataxia. In acquired versus inherited, it is often difficult, especially in the absence of positive history. In acquired etiology may compound an inherited neurological defect, and a rapid or accelerated neurological decline suggests superimposed acquired etiologies more susceptible to injury from the metabolic and toxic insult. In electrophysiology, the hereditary demyelinating neuropathy, there will be uniform slowing of conduction velocity, no conduction block, no significant temporal dispersion. Median and ulnar motor conduction velocity difference will be less than 5 meter per second, and proximal and distal nerve segments are equally affected. In diagnostic approach to CMT, the algorithm emphasize the phenotype and NCV guided testing first, and reserving the exome and genome sequencing for the genetically unsolved cases. And in treatment, CMT is management is mainly supportive, multidisciplinary, and prevention focused. Emphasis on the proper foot care, physiotherapy, genetic counseling for the family planning and prenatal advice, and no disease modifying therapy currently available despite advances in the genetics. However, there are latest trial. The one mutation is that is SORD, which causes CMT SORD, which is now recognized as the most common autosomal recessive axonal CMT, in which there will be sorbitol dehydrogenase deficiency and sorbitol which will be increased, for which the drug that is govorestat, that is aldose reductase inhibitor, is currently in phase 2 or 3 trial, with early recognition of CMT SORD is increasingly critical as disease modifying therapy approaches. And other is NMD 670, that is Synapse CMT phase 2 clinical trial, which target the neuromuscular junction transmission deficit to potentially enhance the muscle strength and endurance and daily function in the CMT patients. The gene targeted therapy in CMT, that is CRISPR and Cas9, or the viral vector mediated gene therapy, and antisense oligo nucleotide and nanoparticles. These are they can be think about in the future, but these are animal trials are going on, but no not yet completed. And this is thank you.
Much for the great presentation. So I think some of the other one or two things that we wanted to address is one is regarding the inelicitable responses on NCV. So
Yes, sir.
so when you get that, I think probably we should also do proximal conduction studies, like stimulating the brachial plexus at Erb's point and recording. That might
Yes, sir.
help you out in classifying demyelinating and axonal. The other
Okay,
thing
sir.
is on imaging, probably to look for thickened nerve roots as a
Yes, sir.
true to CIDP,
Yes, sir.
even inherited also.
Inherited neuropathy.
Also, so both, yeah.
Yes, sir.
It is inexcitable electrophysiology, and you find markedly enlarged nerves. That indicates a demyelinating process that is going on. So
Yes.
that,
Yeah.
I think that was a great presentation, a good learning experience. Thank you,
Thank you,
Dr.
sir.
Sandeep Kaur. Thank you, Dr.
Thank you.
Thank you,
Raj.
Dr. Sandeep.
Thank you, sir. Thank
All
you,
of
ma'am.
would have learned immensely. So we'll now move on to the next speaker. So I would like to introduce and invite Dr. Ilavarisi, who is Associate Professor in the Department of Neurology at AIMS, Delhi. So I request Dr. Ilavarisi to take over the session.
Thank you, ma'am. Thank you, Dr. Saraswati and Dr. Jyotsna and the entire YNF forum and Dr. Madhu for giving us this opportunity. I would like to call upon Dr. Chaitra to start the presentation. Chaitra, please.
Good afternoon, respected faculty and my dear colleagues. First of all, I would like to thank for this opportunity and especially Dr. Ilavarisi ma'am for the opportunity. I will start my talk. It is a short talk. Basically, we have tried to cover all the phenomenology of eyelid movement disorder. I hope it will be useful and we will learn something. So let me start with introduction. So eyelid movement disorder constitute a heterogeneous group of neurological conditions characterized by abnormal eyelid position or involuntary eyelid movements. So either it can be involuntary excessive closure or impaired opening or other abnormal movements which we will be seeing in our talk. And why it is important to know, because they cause a significant functional impairment, social embarrassment, and impaired quality of life. And it is one of the important thing to clinically recognize and advise appropriate treatment. It can range from benign self-limiting conditions to serious neurological diseases too. So, like in we know that for eyelid opening and closure, we have muscles including orbicularis oculi and levator palpebrae superioris, the abnormalities of which we will lead to most of these conditions. Like for orbicularis oculi, overactivity will cause blepharospasm, or it can also be seen in hemifacial spasm. Underactivity or weakness can be seen in myasthenia or muscular dystrophies. Whereas levator palpebrae superioris related conditions also we will be seeing later. And in case of normal muscle activity, also there can be difficulty in opening the eyelid, like in apraxia of eyelid opening. So these are the muscles, the mainly orbicularis oculi, which is needed for the eye closure, and then levator palpebrae superioris, which aids in opening of the upper eyelid. So let's quickly begin with phenomenology. So I would like to discuss regarding this video. So can anyone say what we can see here?
I think you can ask them to type the answer in the chat box.
Yeah, you can type the answer in the chat box. Okay, I'll just explain it. So basically here, like as we can all see in this video, so there is involuntary contraction of both the upper and lower eyelid. So basically the orbicularis oculi, which is seen more in the right when compared to the left. So he's trying to open it like by elevating the eyebrows, but there we can see the contraction of both the upper and lower eyelid. So likewise in this patient, what we can see. As and when the videos are playing, you can type your opinion on the chat box also. So here also we can see there is involuntary contraction of bilateral eyelids with some frontalis overactivation, and it is also associated with some platysma contraction. So these both are different patients with almost similar presentation. Like we will see the rest too also, and then I'll be describing what it is exactly. So here also, like we can see, the patient is having involuntary contraction of both the upper and lower eyelid. But what we can see in this video is there is also contraction of the facial muscles on the same side. So lower face and upper face both are involved. Likewise, in the second video, even though subtle, but there is contraction of bilateral upper and lower eyelids, more on the left side. We can see some lower face involvement also on the left side especially. So what are these? What is the common thing that we can see in all these cases? So I think no one has
For
answered.
the benefit of the audience, I will just summarize and point out a few things. So what we have to observe is where most of the times the patients, these sort of patients, they come and say that they are not able to keep their eyes open. When they are not able to keep their eyes open, you need to see whether it is because of problems with the levator palpebrae, which is not elevating the eyelid, or it is because of the orbicularis oculi, which is contracting. How you differentiate? The levator palpebrae superioris is inserted into the only the upper eyelid. So you look at the lower eyelid and the entire circumferential portion of the eyelid to see whether there is overaction and contraction of the lower half of the eyelid. That will help you differentiate whether it is because of overactivity of the orbicularis oculi. In that case, both the upper and lower eyelids are involved. In contrast, if there is underactivity of the levator palpebrae, only the lids will get repeatedly, there will be repeated blinking, or there will be ptosis, as we will be seeing in the subsequent videos.
Okay. So here what is common to all of this video is blepharospasm. So it is characterized by involuntary recurrent contractions of the orbicularis oculi muscles, wherein both the upper eyelid and lower eyelid will be involved. So this is involuntary, this causes involuntary eye closure, and also there is effortful opening. And it is the most common focal dystonia, usually more common in women when compared to men, in the age group of 50 to 70 years. It is rarely unilateral, mostly it is bilateral. That is one of the clue. And sometimes it can be triggered by tension, anxiety, fatigue, and relieved with some specific movements like touching the face or eyelids or talking or singing at times. The second part of the video, what I showed, wherein the lower part of the face is also involved. So this is called, if there is a blepharospasm with oromandibular dystonia also, or lower part of the face involvement, we call it as Meeks syndrome. It's also most common in females, and it causes involuntary lower facial masticatory movements like lip pursing, chewing, opening or clenching associated with blepharospasm. And initially, why it is important to notice why we are discussing here is because it can present as unilateral blepharospasm in about one-fourth of the patient, and then it can also involve lower part of the face and then progress into Meeks syndrome, usually in a span of 1 to 2 years. And most of these patients also exhibit sensory tics like talking, pulling the upper eyelid, or just touching above the eyes, or blowing of the cheeks, walking, yawning. All this causes betterment in the symptoms and help in opening of the eyelids. And they are also seen to have some responsiveness to alcohol intake also. So let us come to the third phenomenology. A similar patient. So here also the patient came with complaint. He's a 54-year-old male. He is a 54-year-old male. He came with complaint of drooping of both eyelids for around 2.5 years. It was insidious onset, gradually progressive, and also gave some history of diurnal fluctuations. And so he was evaluated outside for the same complaint, and he underwent multiple tests, and acetylcholine receptor antibody was one among them, which was tested positive. He was also underwent a RNST, which was negative. But let's see the phenomenology, what he has.
आंखें कस के बंद कीजिए, अब खोलिए.
So, like we can see, he's having, it seems to be like excessive blinking. There is some contraction of eyelids, which is present.
क्या करने से खुल जाएगा?
So, intermittent involuntary closure of the eyelid is there. And when asked what helps in opening the eyes,
खोल के रखो दोनों. ऐसे.
मांगते थे कि परवरदिगार आंख खोल तो पूरी खोल.
सोने से.
So he is telling when he is touching the upper eyelid or trying to open it with his finger, so it is better. It helps in opening the eyelids better. In the later part of the video, we are just trying to see if by opening the eyelid, if the drooping worsens or not, which is not present. So basically why we had put this video is sometimes it might be confusing because all these eyelid movement disorders are almost sometimes appear similar, and it will lead to misdiagnosis. So the subtle clinical clues which we have to pick up for accurate diagnosis and management. So in this case, even though he came with such complaint and he was tested positive for acetylcholine receptor antibody, the clinical examination shows that there is involuntary contraction of both the eyelids, both upper and lower eyelid is involved, and there is no persistent drooping which is present. It is intermittently present. And typically he says that once he touches the upper eyelid, he is able to see better, like he is able to manage to open the eyelids better. So this is also a blepharospasm, but misdiagnosed as myasthenia initially. So coming to phenomenology 4. So here we can see the patient is having bilateral ptosis and intermittently is also having some closure of the bilateral eyelid. What do you think the patient has? Anyone from the audience? Can you take a guess what this is?
Again, the answers can be typed in the Q&A box.
Yeah. You can see both the videos. Play once again. At the onset, so patient is having involuntary contraction. There seem to be contraction of both upper and lower eyelid. He is also having increased blink rate. But there are some subtle features we have to look into in this case. Like when he is trying to look up, like here, when he is trying to look up, there is also an upward movement of the eyeball. And then when we are trying to open one eyelid, the drooping on the other side is increasing. Note that. And in the second video, when he's asked to look straight, there is some convergence of both the eyeballs. You can look once again. Yeah. So here, even though in the first video, when you see initially, he has contraction of bilateral upper and lower eyelid, and it seems to have an increased blink rate, and it seems to be like a blepharospasm. There are certain other features or red flags which make us think otherwise. So this patient was initially diagnosed as blepharospasm, and however, there was no response to botulinum injections. But on clinical examination, he has some red flags, and there is a enhanced ptosis sign which is present, and there is also convergence which is present. So then this patient was later diagnosed as myasthenia, and he has good response to pyridostigmine. even though he was tested negative for AChR antibody. So this is a similar patient of myasthenia wherein he has ptosis bilaterally. And even though subtle, there is some increase in the drooping of the opposite eyelid on lifting the one side eyelid. Okay. So myasthenia gravis is again another differential when patient presents with the difficulty in keeping his eyes open or some eyelid opening abnormality. So it is purely ocular myasthenia is more common in males over the age of 40 years. And they present with fatigable weakness which improves with rest, ptosis and diplopia. And ptosis mainly is because of the involvement of the LPS complex here. And there are certain signs which we have to look into which will aid in diagnosis of the same, like Cogan's lid twitch, wherein there occurs a quick overshooting of or upward movement followed by a downward drift of the upper lid after the patient performs a saccade back to primary position from looking down, at least for at least for 15 seconds. When we ask the patient to look down for 15 seconds and is asked to look up, there will be a overshooting upward movement which is called the Cogan's lid twitch. And patient can also have peak sign, inability to keep the eyes gently closed. So there is a small lid separation which is seen because of the orbicularis oculi weakness. And like we saw in our patient, enhanced ptosis sign also will be positive, like lifting one eyelid leads to worsening ptosis in the contralateral eye. And the patient can also have lid lag because of overaction of the LPS. And in the second video, what we saw, that is Bell's phenomena with convergence or paradoxical convergence on eye closure. This is seen when the patient is asked to look straight with eyes open. There is a sudden brief convergence of bilateral eyelid. So these all point towards, in our case, aided in diagnosis towards myasthenia. And another important like IcePack test we can do, a simple test which can help in diagnosis. And obviously there are also electrophysiological tests like RNST which we can do to aid the diagnosis.
One of the things that would like to add between the two videos is that
Yes, ma'am.
when a patient has ptosis, like this patient, whom
Yes,
you
ma'am.
showed, the next slide, phenomenology.
Yes, ma'am.
Usually we expect the frontalis overactivity leading to or reflex extension of the neck so that the patient can see through the tossed eyes.
Yes, ma'am.
The patient with ptosis due to myasthenia, which is not seen in the previous two, the previous slide, phenomenology 3.
Yes, ma'am. That is why it was confusing here. Yes, ma'am.
It is
Yes,
fantastic.
ma'am, I agree. Sometimes we have difficulty because these patients with ocular myasthenia may also have associated facial weakness, and I think that may be a confounding thing. But
Yeah,
but
because
I
this
agree.
person appears to be actively contracting the this muscle is
Procerus.
procerus. He appears to be actively contracting the procerus. So, but very interesting. It's a good case collection.
Yes, ma'am. So let us move to the next phenomenology. So I want audience to answer in the chat box so that it can be.
पापा आंख बंद करिए
आँख बंद कर लो
जोर से बंद करिए अभी खोलो आंख बंद करिए खोलिए
Any guesses what it is? Diagnosis? Okay, let's see what we can see here.
एक छोटी
So
पापा आंख बंद करिए
here the patient is asked to close his eyelid. So
आँख बंद कर लो
he does it.
जोर से बंद
So after that, when he is asked to open, yeah, when he's asked to open it,
आंख बंद करिए
he takes some time.
आंख बंद करिए खोलिए
And then he opens it. So he quickly cannot perform that action when he's asked to open the eyelid. So this is apraxia of eyelid opening. So here there is difficulty in initiating eyelid elevation following sustained voluntary eyelid closure, without any evidence of involuntary orbicularis activity. Like we saw in the video, there is no contraction of upper or lower eyelid, but when voluntarily he is asked to open the eyelid, he is not able to do that. So this is, there are many hypotheses that is proposed for the same, but most commonly accepted is the persistent of levator palpebrae inhibition. So whenever the patient is closing the eyelid, there is inhibition of the levator palpebrae muscle activity and the orbicularis oculi is acting. So when the patient is asked to open the eyelid, the inhibition has to go away so that he can open the eyelid, wherein this is affected in apraxia of eyelid opening and there is persistent inhibition of levator palpebrae activity. So, however, it is important to note that spontaneous and reflex blinking will be normal in such patients. When they are spontaneously talking or eating or doing any other activity, the blinking will be normal and they will be able to do it. But when patient is asked to open the eyelid, he will not be able to do. And initially, this is a misnomer actually. It is not exactly an apraxia. There have been multiple names for the same, but ultimately now currently we are using this only. It is said to be of supranuclear origin. And so in this case also there can be compensatory hyperactivity of the frontalis muscle when trying to open the eyelid. And 1/3 of them also report that touching on the eyelids will allow easy opening of the eyelid. And it's important to note that it can be associated with blepharospasm and many other neurodegenerative diseases also. So it can provide us a clue for in the initial stages. It can be the initial manifestation also in such cases. And why it is important to differentiate between blepharospasm or apraxia of eyelid opening is the treatment options. They might not respond well to botulinum toxin injections, and specifically, even if we are injecting, pre-tarsal regions have to be injected. So, clinical examination and identification whether it is blepharospasm or apraxia is very important in such patients.
If I may add something here. So when we are giving toxin injections, we should be very careful in these sort of patients. Always counsel them about the expected risks versus benefits. So as you know, sometimes patients who have even blepharospasm, when you are injecting, if the toxin spreads into the LPS, patients may develop ptosis as an adverse effect. So always make sure that Chaitra very well showed the initial pictures where if you see that the levator palpebrae superioris get inserted into the tarsal plate in the preseptal region. So when you are giving toxin injections, always make sure you inject into the pre-tarsal part of the orbicularis oculi, which is inserted on the border of the eyelids, the upper border of the, in the upper eyelid, just above the eyelashes. And in apraxia of eyelid opening, there is no need to inject the lower part of the orbicularis oculi, even though it is said that in some patients the orbicularis oculi overactivity is present. Always inject only the upper eyelids just close to the eyelid margin and a lesser dose as compared to what you inject in blepharospasm. Because in blepharospasm, the orbicularis oculi is actively contracting. So it needs more toxin dose to counteract the overactivity. Here it is just persistent orbicularis oculi activity rather than a persistent tonic or a phasic contraction of the orbicularis oculi. That is an important distinction to identify and plan your toxin dosage.
Okay. And then this is another interesting case. Audience can actually
करो कोस्की बंद
answer.
खोलो फिर से करो कस की छोड़ो फिर से करो कस की छोड़ो फिर से करो.
Okay. So what we can see here is, so the patient is asked to close the eye tightly and then he is asked to open the eyelid. So when he is,
जाओ करो कोस्की बंद
so he is able to close it when on commands, like he is able to close it well. There is no problem in it.
करो कोस्की बंद खोलो
And then when he is asked to open, so he is having some difficulty, but however he is able to do it, but very slowly.
फिर से करो कस की छोड़ो, फिर से करो, हस्की, छोड़ो,
Huh. And he's also using his support of his frontalis and to open the eyelid. So this is a case of eyelid myotonia. So it is difficulty in opening the eyes after forced sustained eye closure. Because of post tetanic facilitation, if you ask them to do it repeatedly, sometimes they will be able to do it better. And sometimes, yeah, even in these conditions, if we are not aware of such condition, it might be mistaken as other like blepharospasm, etc., and myasthenia in patients like this. So we have to pick up certain clinical clues and some other things which will help us in diagnosis. Like for example, in myasthenia with the cold or ice pack, it improves. But in this case, there will be aggravation by cold because of the vasoconstriction which occurs because of the cold, and there will be metabolic slowing which interferes with the muscle activity. It can be associated with various neuromuscular disorders like sodium channelopathies, myotonic dystrophy, and sometimes it will be the initial presentation of such cases also. So careful examination will help us pick up this. And there are also some case reports wherein even in myasthenia gravis patients, they can exhibit mild myotonia too. And it is a tonic muscle response.
So here I would like to add a few points. So this patient actually was referred to us as a case of apraxia of eyelid opening, and sent for botulinum toxin injection. So interestingly, I kept this patient in one of our DM exit exams, and I put it as a spotter. So like there were some, I think 7-8 candidates. Half of them had diagnosed it as myotonia, half had diagnosed it as apraxia of eyelid opening. Of course, it is a very confusing case, so I gave credit to both of them because it is of course a strong differential, and we had marked all of them to have answered correctly. But there are key points to differentiate, especially in cases with myotonic dystrophy. Patients may also have associated facial weakness. In such cases, if you inject toxin, it may lead to worsening of weakness. So you should always be very careful before you look for other signs. Look at the tongue. You look at the general examination is very important. Just because we say eyes are the windows to the brain, but we just don't peek through the windows. You need to go inside to see actually how it looks from inside. So careful examination actually gave us the diagnosis. That is one thing. The second thing, we also saw a very interesting previous patient in whom there was neuromyotonia. So neuromyotonia has to be differentiated from myotonia. In myotonia, there is delayed relaxation of the muscle after it is contracting. So usually after voluntary contraction, there is difficulty in letting go because of difficulty in relaxation. On the other hand, in neuromyotonia, it is because of overactivity of the nerves, which leads to contraction of the muscles because of a channelopathy. Both of them are because of channelopathies, but the primary driver of the abnormal movements is muscle in case of myotonia and the nerve in case of a neuromyotonia. That is another thing that we need to remember.
Okay, thank you, ma'am. Another phenomenology. So there are two different patients. These are two different patients. Just observe what is happening. Okay. So in the first video, she is a young female. So she's having this sudden backward bending of the neck, and associated with this, there is some eyelid closure also, an opening of the mouth. So recurrent episodes, such episodes she is having. So this patient was he's a diagnosed case of SSP. So the second patient, she has history of associated history of generalized tonic-clonic seizures, and recurrent eyelid blinking. So what we can see in the first video is the patient is having a sudden onset jerk, which involves extension of the neck, backside, opening of the mouth, and there is some eyelid closure. And the second one, she is having sudden eyelid closures, brief, which appears like increased blink rate. So both of these conditions are, both of these patients are having eyelid myoclonus, but the presentation of both the patient is different. So talking about eyelid myoclonus, it is considered as a seizure type rather than a movement disorder. Most commonly, it is described in G1 syndrome, wherein it is precipitated by some slow eye closure and some cognitive task. And more typically, they have eye closure sensitivity, and they close the eyelid. It occurs more, and they've also like this. Other than these condition, what we have to see here is in our patients. First patient is of SSPE, and the second patient was fitting into, like, she had a GTCS, she had minimal cognitive impairment, and there was also some ataxia which was present. And the age of presentation, age of symptom onset was around 12 to 13 years. So we were thinking the patient has a PMA spectrum disorder. However, the genetics of the patient is awaited, but clinically she was fitting into the same. So in both these patients, we can see that there is some eyelid movements, especially in the second case. So most of the time, such subtle manifestations are thought of as increased blinking, and or the patient is doing voluntarily, and it will not be usually picked up. So it is important for us to notice it and pick it up so that it can aid the diagnosis and help in early diagnosis and treatment of such cases. And even
I
in
would like to
SSP,
add. Oh, sorry. Go ahead.
even in SSP, usually there are some 3 to 4 papers which has come out in jaw opening, jaw opening kind of dystonia and movements, and also such kind of extension of the head. Because usually myoclonic jerks, there will be some axial involvement is there, upper limb involvement is there, and there will be flexion. Extension and eyelid myoclonus is very rare. So there is only one case which has been reported in SSP patient who had a eyelid myoclonus, and it's not very common, but however uncommon presentations we have to be aware of so that we can pick it up, and that will help in diagnosis and management.
So I would like to add a few things. We had put both of these patients together because if you see, the first patient is having a myoclonus of the eyelid. The eyelids are just quickly jerk. It is a jerk-like blink, but it is a negative myoclonus. It is because the levator palpebrae superioris is suddenly losing tone, and that is leading to the myoclonus, which is a negative slow myoclonus. Now, contrarily, if it is because of orbicularis oculi overactivity, as we had seen, both the upper and lower eyelid, both of them would be contracting briefly and then relaxing. That is the first thing. In the second video also, you see a slow relaxation phase of the eyelid when it is opening. So what we wanted to show is slow myoclonus is characteristically seen in SSPE, but we can also see this in sometimes in dystonic disorders. And in this particular patient, she had a Unverricht-Lundberg-like phenotype. So the genetic, we are trying to get the genetics for ULD, and skin biopsy is also being planned, but the results are not yet. We haven't got it back yet. These two patients have a similar phenotype but different diseases. The second patient we had to admit and evaluate because initially in the OPD we thought probably it is SSPE. We admitted for a CSF and other detailed evaluation including EEG. But then the rest of the phenotype and as well as the progression and the long duration of illness took us away from SSPE. We also did a CSF and other EEG testing also. The tests were negative for measles.
Yeah, that slow myoclonus that happens. Sometimes with that slow myoclonus, the patient has a vacant stare in the eyes, a blank look in SSP. That is quite typical. And in the epileptic myoclonus, this G1 syndrome, they may have additional features like light sensitivity, and that is another point with this. So it is very nice to see both the cases side by side too. demonstrate that.
This one. And last phenomenology is this particular patient. So let's see what's happening here. So she's having difficulty in keeping her eyelids open, and there is increased blinking. There is some frontalis activity also. And she says on when she's touching one eyelid, the other eyelid opening is better. And sometimes it is asymmetric also. She's having some winking movements. Okay. So what this can be? See, she's having some asymmetricity. She's having winking movements sometimes and some frontalis activity. See this fluttering, blinking movements. Okay, so patients can present like this also to our movement disorder clinic. So this is a functional eyelid movement disorder, last but not the least. So it can also mimic blepharospasm, apraxia of eyelid opening, and other abnormal eyelid movement abnormalities. So what we have to pick up here is sometimes it can be present only in certain positional provocational maneuvers and not during casual examination. And usually, whatever reports have been till now, they've noticed that mostly they present with frequent blinking, and sometimes they might have recurrent Bell's phenomenon also when they've asked to open the eyelid, and they will have distractibility, variability, and inconsistency, which we have to pick up. So by that we can differentiate. Yes, we will do certain routine examination also, but clinical examination is important here. So this was the last phenomenology. I would like to conclude by telling that eyelid movement abnormality are a heterogeneous group of neurological condition characterized by abnormal eyelid position or involuntary eyelid movements. They're common but under-recognized and is often misdiagnosed because there are only subtle changes between each phenomenology which we'll have to identify. So careful observation of phenomenology is key for proper diagnosis and appropriate management. And since they cause a significant impairment in quality of life and functional disease burden is also more, early recognition will improve the quality of life. Thank you. Any questions are welcome.
Thank you, Dr. Chaitra, for that wonderful presentation. Dr. Nilesh was asking to describe phenomenology 4. If the chairpersons agree, then, and if we have time.
We can, I think, yes, we can. Please show the phenomenology 4.
Sure, ma'am. I think this particular video. So here we can see the patient is having contraction of bilateral upper and lower eyelid, and there's also some overactivation of the procerus which is present, and he's having difficulty in keeping the eyes open. Here in between, so when he's trying to look up, so he's having this quick Bell's phenomena which is present, and on opening one-sided eyelid, when lifting it up, there is increased drooping on the other side. You can observe it. I'll show once again. Yeah. And in the second video, so when the patient is asked to look straight, there is convergence of the eyeballs which is seen. Yeah.
So I know this video is quite a controversial video. Basically, I get reminded of another case which Dr. Soham once presented in the video challenge in International Association of Parkinson's and Movement Disorders. That patient was going around for some 20 years to various practitioners. Some were saying it is myasthenia, some were saying it is blepharospasm, some as apraxia of lid opening. The patient had all sorts of labeling, and ultimately it was picked up. So that I remember that case because Dr. Kailash Bhatia picked up this point of the uprolling of the eyeball when the patient is blinking. That we can see in this particular video. I think in 38 seconds you will be able to see that. Play it and you can just 35 से 38 में play करो. You will be able to pick that up. When he blinked, the eyeballs rolled upwards. So he said that is the clue, because in patients with ocular myasthenia, there is associated facial weakness, and because of blinking, the eyeballs roll up. In case of blepharospasm, the orbicularis oculi is overacting, so you will not see the Bell's phenomenon in that particular case. So then this patient also was referred with all sorts of diagnosis, has received toxin injections once or twice. Then I sent the patient back and I said, after the toxin effect wanes off, you come back again, then we will examine. Because when the toxin is injected, of course, we are weakening the eyelids. It is difficult again to find out whether there is a associated weakness or it is overactivity. So this particular patient had this one. This was this one thing. Then second, we were able to demonstrate the curtain sign, and thirdly, in some of the videos, you are able to clearly appreciate the asymmetric ptosis and eyeball movement abnormalities also, which led us towards a diagnosis of ocular myasthenia as compared to blepharospasm. I think the other panelists also can add their views, and if there is a difference of opinion, of course, in movement disorders, it is sometimes very difficult to make the diagnosis at the first instant, and only close follow-up over years, the diagnosis may get revised also. We have seen such cases as well. So I think as a clinician and as a neurologist, I have a diagnosis today, but I should be humble enough to accept if the diagnosis changes in future. And I would request the other panelists who are neuromuscular experts, Madhu ma'am and Saraswati ma'am, to also give their opinion.
Yeah, I agree with you that we should keep our minds open, and there's nothing like serial follow-up. That's the best tool that we have to, make a diagnosis. Sometimes when we see the patient the second time or third time, we may be able to make a better diagnosis. Not only in this case, but in many cases, we've seen that when we see the patient the second time or the third time, then it really helps us to make the accurate diagnosis.
Yeah.
Of course, it's
Saraswati
a
ma'am?
very challenging case.
Yeah.
I think blepharospasm being misdiagnosed as myasthenia and myasthenia being misdiagnosed. One is common, the other one is little difficult, like you showed in this case, no? Myasthenia being diagnosed as blepharospasm. It's a little very complicated, and I agree with Madhu madam totally that we have to follow up and only then we will know. So all these disorders, they wax, wane kind of this thing. So we'll require follow-up.
So yeah, I have quite a short follow-up. I saw him first time in August, and almost 4.5 months. I've called him again in June. The good thing is he's a very, very adherent patient. Whenever I call him, he just comes. So that is something, these patients, they are teaching us so that we can help diagnose patients better in future also. So I would, of course, thank all the patients who agreed, consented for videos, as well as we take consent, like we could use this for teaching neurologists all over the country. And I thank all the patients and their families for giving consent. And also Dr. Chaitra for putting in all the hard work and making the presentation. She had made the presentation like at least 1 week in advance, and she was sharing with all the panelists. And also Saraswati ma'am is very particular in getting things done on time. Thank you ma'am, for keeping us on our toes and making this presentation a grand success. Thank you.
Thank you, ma'am.
Yeah, I really appreciate Dr. Chaitra and Dr. as well as Dr. Sandeep Kaur as well for that, that systematic and methodical way of presentation without hurrying, of course, Dr. Sandeep had to hurry up in the end to make space for the second speaker. But then it reflects the maturity of thought process as well as the knowledge base. So it was the way you presented and explained was also very good. It was not simply reading from the slides or, wrote a kind of a presentation. So both Dr. Chaitra and Dr. Sandeep, I appreciate that for that quality of presentation.
Thank you, ma'am.
Thank you.
To
Thank
Dr. I hand over
Absolutely.
to Dr. Saraswati and Dr. Jyotsna for.
Thanks to
Saraswati,
our
anything from your side?
moderators.
Yeah.
Yeah, thanks to our moderators for this enriching academic experience. Dr. Josna will now conclude.
Yeah, I thank the presenters, Dr. Sandeep, Dr. Chaitra, for doing an astounding job of hard work, effort, and clarity in concepts and presentation. I really thank the moderators, Dr. Sumant, Dr. Elavarisi, and Dr. Madhu for excellently moderating the session. You really brought out the crux of the issues and a wonderful discussion, a wonderful potpourri of the eye movement cases. And I encourage all the participants. We had 130 plus participants for the session. And I encourage all the young neurologists out there, please help us, support us, and share your cases and present your wonderful work that you've been doing. And anything else, Saraswati? I think we'll conclude the session. And I thank one and all of you for making our debut a grand success. Thank you.
Thank you.
Thank you.
Thank
So I
you.
formally
Thank you.
conclude the session. Thank you all.